there were a lot of things that came out for the DCB scenario. So let's start immediately with the first presenter, which is Aloke V. What are the challenges for Sirolimus coated balloons? Will they work as Paclotax? Aloke, please.
Great, thank you so much. Here are my disclosures. So we're here to talk about Serolimus coated balloons this morning. And this illustration, I just wanted to show you a little bit of historical perspective. I think in each wave of innovation in interventional cardiology or revascularization, we've improved the previous technology with something new. It hasn't always worked out with the BBS, but for instance, I believe now our first generation DCBs will be improved and will be overcome by second generation Serolimus coated balloons. As you all are familiar with, the current state of the situation is that paclitaxel is the major drug used in drug-coated balloons. It has been for many years now, and there are many that have been approved for the SFA indication. But as you know, they have certain weaknesses, and one of the weaknesses, of course, is the use of paclitaxel, especially in its crystalline form, which you see produces drug depots. And those depots are the way that the drug is delivered over time to be successful in terms of minimizing restenosis. The problem, of course, is the coating. The coating of these balloons is really not very good in terms of ability to conform and stick and transfer to the arterial wall. And that really means that the transfer and loss of paclitaxel into the body and into downstream tissues is substantial. And as you all are familiar with, Serolimus is the go-to standard for coronary artery disease treatment via DES. It's certainly the more accepted drug versus paclitaxel. And we've shown in various animal models evidence that paclitaxel crystalline form embolized in the downstream tissues, especially in the porcine SFA model, where it embolized in downstream skeletal muscle tissues where it really shouldn't be. And this is one of the major concerns with the technology. In the coronary, I think this is even more of a concern, frankly, because the heart is, as you know, a very oxygen-rich organ, and it really depends on a lot of microvasculature to function properly. Any emboli are not well tolerated by the heart. And that's shown here in these two reports of slow flow after paclitaxel-eluting balloons in the coronary, as well as one where it was shown the coronary flow reserve was significantly impaired after paclitaxel balloons. And of course, we know that these balloons don't work very well in terms of if you have slow flow in this particular paper, you had impaired wound healing in patients with CLI, and the amputation-free rate was significantly decreased if you had slow flow after paclitaxel-eluting balloon angioplasty. And of course, paclitaxel is well known to be a chemotherapeutic agent, and it's well known to have toxicities at certain levels. And that's another concern that really was heightened by the Katsanos meta-analysis and still hangs over the field to this day. Now, in terms of Serolimus, we certainly know if you compare late loss numbers for Serolimus DES versus paclitaxel, is simply superior. Serolimus is probably a better drug for preventing intimal formation and restenosis than paclitaxel. And one of the reasons, of course, is that Serolimus is cytostatic. It's a safer drug. Its therapeutic index is much wider. It really inhibits the replication between the G1 and S phase in terms of proliferation, whereas paclitaxel is a cytotoxic drug. It really relies on killing cells in the M phase in order to work. One of the issues with paclitaxel, of course, is it partitions in the subintimal space and significantly in the adventitia and forms a drug depot. It really is probably a better drug in terms of having its own depot within the artery wall. Serolimus really diffuses slowly throughout the artery wall and quickly gets out of the artery if it doesn't have some sort of carrier or drug depot. Now, the issue with Serolimus-coated balloons, and the reason why they're behind, I believe, paclitaxel in terms of development is because it's more tricky to get Serolimus to stay there. You have to enhance its tissue absorption, and you have to extend its time in the artery wall in order for it to be successful. And in order for it to do that, demonstrate efficient transfer and sustained drug delivery, the mechanisms of delivery have to be more complex, perhaps, than used for paclitaxel-coated balloons. And the effects of excipients and carriers have to be very closely examined for this particular technology, simply because they're probably more complex than what was used for paclitaxel DCBs. So what is required to show safety in animal models? Obviously, if you want to go to humans, the first important step is to get approval and safety demonstration in animal models. So the three things I want to point out are you really need to evaluate time points during drug presence and at least one time point after its absence to make sure that you've got the excipients, carriers, do not cause any evidence of vascular toxicity, which may only be manifest when the drug is gone. So it's extremely important to go past the time duration of drug release. What about downstream organs? Did you get emboli in downstream organs? Was there damage in the heart? Did those downstream emboli cause infarction or scarring of the heart? These are things that really need to be looked at closely in animal models before technology can be adapted for humans. And what about non-target organs? Did they affect non-target organs? Was the delivery of the balloon, in the course of its delivery, did it embolize? Did pieces of that flake off and go to the kidney, other organs, cause infarction or microemboli? Those all need to be looked at. Now, these are some examples of common sirolimus-coated balloons that certainly have CE mark. Both the Magic Touch and Solution balloons both have CE mark, and they're both looking to get FDA approval. Of course, they're both share a common thing, which is they're not just sirolimus. They don't share, but they both have carriers that assist in the delivery and sustained release. For Magic Touch, it's submicron phospholipid particles, which encapsulate the sirolimus. For this Meta-Alliance balloon, it's really micro reservoirs made up of a biodegradable polymer intermixed with sirolimus, and that really causes sustained release over time. And you can see in the PK models done in animals that you do get sustained release of sirolimus over time if you assay the tissues at different time points. For Magic Touch, the curves look like this, but you do get some detectable sirolimus out to 30 and 60 days. For Solution, it's more like this. You can see here Solution has a very good curve in terms of sustained release sirolimus over time, probably because of those PLGA particles that help it to release over time. You can see that's very similar to the pattern shown by Xience, which is a drug-eluting stent. So in the FDA model, when we do these models for FDA evaluations, they really do want to see for coronary ISR. As you know, the ISR indication, stent restenosis, is probably the primary indication these balloons will go for. And what we do in the pig, just to explain it to you, is we basically at day 0 put a bare metal stent in the animal, we deploy it, we come back at day 28 where there's some intimal formation that's formed, and then we'll treat that with a DCB, and then we'll harvest the animal at later time points, 30, 60, 90, 180 days, to get the full time course of what this looks like. And this can be done with the assistance of also measuring troponin levels around the time of the interventional procedure to see whether or not there were any damage to the heart that was done or periprocedural MI that was done during the time of deployment. And of course, these balloons are already beginning, the sirolimus-coated balloons, to show efficacy in humans. This is data from the Solution balloon that I showed you earlier. Looking at first in man for the SFA, you can see late loss was 0.19, very acceptable, probably even better than what's been shown with paclitaxel balloons. And you can see first in man Solution de novo coronary, I think, was presented at this meeting earlier. And you can see mean late loss numbers are in the 0.16 range, extremely good at 6 months. So I think these are competitive and basically as good in some ways as a stent in terms of late loss numbers. So in summary, sirolimus, I would tell you, is the preferred drug for intravascular interventions. Paclitaxel-coated balloons are limited by high rates of distal embolization and loss of paclitaxel into the body. And of course, the Katsanos meta-analysis only heightened these issues. Sirolimus-coated balloons have demonstrated successful drug transfer into the arterial wall. I did show you that, and have received CE mark approval with FDA submissions, applications ongoing. And safety studies in preclinical models are ongoing, but appear promising, with I think you'll begin to see some IDE studies in the coming year already launched in the United States. Sirolimus-coated balloons, I believe, will become an important technology for the treatment of PVD and CAD going forward. So with that, thank you for your attention.